If there's one thing every skier and active adult should understand about ACL and meniscus injuries, what would it be?
Well, I guess the one thing, again, the take-home message might be that it's a common injury and that people do very well overall. Obviously, every surgery has some risks, but the overall, it's a very common injury, so we're getting very good at repairing these, and that your life isn't over.
Welcome to 518 Thrives Healthcast, where medicine finally makes sense and maybe even gets a little fun. I'm your host, Dr. Disha Spath, internal medicine physician and founder of Thrive Direct Primary Care. And this is the show where we break down real health topics, ditch the medical jargon, and talk about what actually matters for your life, your family, and your future. In each episode, we bring you relatable stories, straight answers, and local experts from right here in the capital region. Because healthcare shouldn't feel confusing, intimidating, or out of reach. It should feel human again. Let's get to it. Hi, everyone, and welcome back to the 518 Thrives Healthcast, the show where we make medicine relatable, practical, and local for families across New York's capital region. I'm your host, Dr. Disha Spath, internal medicine physician and founder of Thrive Direct Primary Care. And today, we're diving into one of the most common injuries we see this time of year in upstate New York, ACL and meniscus tears from skiing in winter sports. Whether you're an experienced skier or someone who finally decided to try the slopes as an adult, no judgment, I may fall into that category. Knee injuries can happen fast, and they can be scary. To help break down what happens, how these injuries are treated, and how patients get back to doing what they love, I'm joined by one of the region's leading orthopedic sports medicine specialists, Dr. Kyle Flick. Dr. Flick is the medical director at Ortho New York's Ambulatory Surgery Center at Executive Woods and a pioneer in sports medicine here in the capital region. He's the first surgeon locally to hold a secondary board certification in sports medicine and has trained at world-renowned institutions, including the Hospital for Special Surgery and Rush University, where he worked with the Chicago White Sox, Bulls, and the Chicago Rush. He cared for athletes at every level, from professional teams right here in Albany to the U.S. under-18 hockey team, to me and my ACL tear recently. And he specializes in arthroscopic treatment of knee injuries, including ACL and meniscus tears. Dr. Flick, thank you so much for being here. I am so proud to have you.
Well, thank you. It's really a pleasure to be here, Dr. Spath.
Oh, it's my pleasure. Let's do a little fun breakout just so we can get warmed up. Before we get into knee ligaments, skiing or hockey?
Oh, hockey.
You're a hockey guy.
Yes.
Who's a tougher patient, elite athletes or weekend warriors?
Now, that actually depends on the sport for the elite athletes. So,
Okay. Which sport's the worst?
lower on the list is maybe soccer players and some basketball players.
Okay.
They may be more difficult to take care of.
All right.
Top of the list are the hockey players, of course. Easy to take care of. But we've got some pretty tough weekend warriors out there, too.
Oh, yeah. Yeah, I know. I'm a terrible patient, so.
No, you're not.
All right. Well, favorite OR music, what do you prefer?
Well, a mix. I actually usually ask the patient what they want, even though they
Really?
might be sleeping. But we go with a lot of classic rock, a little bit of reggae,
Okay.
and whatever the mood is that day.
Did you ask me what my favorite music was?
I didn't.
Okay.
No.
Because I don't remember that at all. I don't remember anything. I do remember coming out of surgery and singing the Harry Potter spoof, where it was like, it was a YouTube video, and it's just like, run, 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 Weasley.
Yeah, I don't remember that, but
And Josh was like, are you okay? And I'm like, yeah, it's Harry Potter.
we gave you some good drugs.
Oh, yes. Yeah, they were great. Thank you. One thing skiers always underestimate about knee injuries.
Probably, at least when it comes to ACL injuries, they probably underestimate the amount of work it takes to recover.
Yeah, tell me about it.
Yeah.
All right, well, let's hop into it. Let's talk about a scenario many people in the capital region can relate to. Meet Mark. He's a 41-year-old recreational skier. He's been skiing for years. He heads out for a weekend trip. He hits an icy patch and twists awkwardly while trying to avoid a fall. Unfortunately, he feels a pop in his knee. This sounds very familiar to me. You have an immediate swelling. He can't continue skiing and struggles to bear weight on that knee. Something feels terribly off. So he goes to the doctor. His MRI shows an ACL tear and a medial meniscus tear. Now, Mark is overwhelmed. Does he need surgery? He's asking, will I ever ski again? How long is recovery? What happens if I fix it? This is exactly where many patients end up. This is where I ended up too. So let's talk about injury mechanics first. What typically happens in the knee during a skiing-related ACL tear like that?
Okay, good question. So the mechanism that was described for skiers tearing their ACL was actually described by a doc at the University of Vermont, where I went to medical school, Dr. Johnson. And it's this term that you may hear called the phantom foot. And what that is it's the back of the ski. When usually a less experienced skier, but even the high-level skiers can have the same mechanism where they're leaning further back behind their hips and they're trying to recover from a fall. And that back of the ski kind of acts as a fulcrum and ends up twisting the knee. And what happens is you just exceed the strength of the anterior cruciate ligament and that tears. A lot of times when that ACL tears, the meniscus can also tear because of the motion that occurs, but not everybody has a meniscus tear.
I see. Yeah, so actually I watched Lindsey Vohn's fall, and when she tore her ACL is very much like that. She's kind of leaning backwards and trying to balance herself out, and obviously a terrible situation for her as well. Why do ACL and meniscus tears often occur together?
Yeah, what happens when the ACL tears is the knee suffers what we call a pivot shift, which is a rotation and a translation of the shin bone or the tibia on top of the femur. And so that rotation, first off, tears the ACL.
Right.
And then the meniscus is the next structure in the knee that's on stretch or at risk. So typically in an acute ACL tear, if it's the first time someone's injured their knee, the lateral meniscus often gets torn, and the medial meniscus can tear also, but that's more common in someone who's already ACL deficient. Maybe they've tried to go non-operatively or they never had surgery, and that persistent instability is now more likely to tear the medial meniscus. But they're probably about 50% of ACL tears are associated with one tear or another of the meniscus.
What are the classic signs of an ACL tear versus a meniscus tear?
Yeah, so an ACL tear is typically, most people remember hearing a pop. They do develop swelling later that day, whereas a lot of times with a meniscus tear, you may not have swelling. The meniscus tear is typically tender directly on one side of the knee or the other, either the inner medial side or the outer lateral side. And a meniscus tear usually gives people a sharp discomfort when they rotate or twist, whereas an ACL tear is more likely described as an instability. Their knee doesn't feel right, it shifts. But the pain after an ACL tear typically goes away within a week or two once the swelling subsides, whereas a meniscus tear will remain painful.
I see. When should someone go straight to the orthopedic doctor versus urgent care versus their PCP?
Usually, if you're having trouble bearing weight and you're in a substantial amount of pain, the logical thing would be to go to an urgent care. I think that's probably the most efficient thing to do. To make an appointment with your primary care is fine, and many primary care physicians have a really strong background in musculoskeletal, but unfortunately, a lot of them actually don't like to take care of musculoskeletal, so they're then going to refer you to an orthopedic surgeon. But the urgent care will do the same thing, and they'll also be able to get x-rays to make sure nothing's fractured. So this could be, a ski injury could be a lot of different things outside of an ACL tear. So an urgent care visit is probably the go-to thing to do.
We're lucky in the 518, actually, that we have Ortho New York urgent cares. So can you tell us a little bit about that? Can you walk in or do you have to make an appointment?
Yes. At Ortho New York, we switched recently to making appointments for the urgent care, and we try to accommodate people for that, or at least give them an appointment with a doctor who might be available quickly. When we had just walk-ins, it really became difficult to manage and to staff properly. So there's on our website, there's the ability to make an appointment even for the same day.
Okay, awesome. Yeah, you just have to sort of hop on there and book a spot. That makes sense. So once the person is in the clinic and they're seeing someone, what role do exam findings play versus the MRI?
Yeah, so we always start with history is the most important part of most medical evaluations, and in orthopedics, it's very true. We almost know our diagnosis just from the history. And then the physical exam is also confirming and very helpful. People always ask, well, why are you getting x-rays? I know I didn't break a bone, but x-rays are always an important part of the evaluation because there are subtle findings on an x-ray that can help us. And then ultimately, the MRI is also a confirming tool, but we try not to use the MRI to make the diagnosis. In fact, an experienced exam on the ACL by somebody who takes care of a lot of knees is probably more reliable to determine an ACL deficient knee than an MRI can be.
Yeah.
So sometimes we're surprised that an MRI says, oh, maybe it's just a little partial tear, but the patient definitely has a very loose knee and you know it's completely torn.
Yeah, that's what happened with me. You examined my knee and you were like, definitely the Lockman test was totally positive.
Yeah.
But the MRI showed maybe it was not a full thickness tear on the MRI, but then when you went in or arthroscopically actually took a look at it, it was a full thickness
Exactly.
tear.
It happens a lot.
Yeah.
Yeah.
All right. Does every ACL require surgery?
Yeah, definitely not. But the vast majority of people that tear their ACL are young and active. And the downside to not stabilizing a knee with surgery is often a quick progression of new injuries. So as soon as the knee buckles again or gives out, that's where, as I said earlier, the meniscus is now at risk. So, and that kind of snowballs into further damage. And arthritis is definitely a fairly common outcome years and years later after someone tears their ACL. We believe that surgery slows that down, but we still, even with surgery, we see a higher incidence of arthritis, but we don't see the rapid progression that we might see without surgery. So someone who is maybe older and less active, but happens to take a fall and tear their ACL, they may not need surgery. They may do pretty well with physical therapy. Somebody who has a very arthritic knee already would not have ACL surgery. They would have knee replacement. So there are these categories where we would not recommend surgery.
Got it.
Yeah.
Okay. So say someone decides to undergo surgery. What does an ACL reconstruction actually involve?
Okay. So to put it simply, the operation is basically restoring this ligament that connects our two main bones in our knee, the femur and the tibia. And that is one of the cruciate ligaments. There's an anterior and a posterior. They cross each other in the middle of the knee. And the ACL is much more frequently torn. And we basically are putting a new ligament or a new tendon. Most of the time it's a tendon that actually the body converts to a ligament over time. But we're basically, think of it as like a rope that's holding a boat to the dock, and you have multiple ropes holding the boat. So if you cut one of those ropes, the boat is still intact and your knee is still intact, but it's moving in and out away from the dock. And so we're just putting a new rope there, basically, and asking the body to heal that. And so it involves choosing a graft, which is going to be the new ligament. And there's a few different options that we choose from. And then the surgery itself is an outpatient surgery that takes about an hour. And patients then start physical therapy within a week or so. And it's a 6-month recovery. 6 to 8 months.
Yeah, so that's the big deal. Is the surgery itself was short, but the recovery, the 6 to 8 months of recovery, that's rough. Tell us about that.
Yeah. So it's rough in the beginning, getting your range of motion back and getting your strength back. And then there's this long period from months 2 or 3 till you're ready to go back to full activities, where it's just a waiting game, where most people are doing very well and living their lives, but their strength isn't back to where it should be. And the actual ACL graft is not strong yet. So in instances where we use a donor graft or from a cadaver, that process of that graft incorporating and being strong, we know can take anywhere from 6 to 8 months. If it's your own tissue, it also takes 6 months. That's kind of our minimum. And so a lot of that 6-month recovery, I have my athletes getting back in the gym. They're riding a bike. They're doing upper body weights, lower body weights. They're actually quite active, even running by 3 months. But it's the cutting and pivoting. It's anything that puts the ACL at stretch that we try to avoid until we know it's strong.
Yeah. That's definitely one of the hardest parts for me right now is just not being able to play tennis for months and months. But that's okay. We're going to get there. We're going to get back to it. It'll be awesome. What happens during a meniscus repair versus meniscus trimming?
Okay, yep. So most meniscus tears are in an area of the meniscus that doesn't get a good blood supply, so it doesn't have the capacity to heal. So that's like a flap of the meniscus that can cause that sharp pain that we talked about earlier when you twist or turn. So that type of a tear, we just remove the part that's torn. It's not functioning, it's not doing its job anymore, and it's causing pain. So that's a meniscectomy where we just remove some of it. If you have a tear that's on the periphery near the blood supply and has the capacity to heal, and if you're younger, by younger I mean like under 30, we're very aggressive about trying to repair the meniscus, so we can maintain that cushioning that's in the knee, that shock absorber. But unfortunately, that's the lower percentage of meniscus tears.
Got it. Are these procedures usually done arthroscopically? Anytime you might need an open surgery?
Yes, sometimes if there's a very large tear in a young person, there are times where we put sutures in arthroscopically, but we open the knee on the side to tie those sutures. That was very common when I was in my training years and years ago. Now there's a lot of devices that are all arthroscopic to do that repair. So I very rarely do any open meniscus surgery at this point.
Wonderful. Yeah, it's amazing how little my surgery shows on my knee.
Yeah, the scars can be small.
Tiny. Yeah. All right. And just for our audience, outpatient versus inpatient for these surgeries.
Outpatient.
Yeah.
Yep.
Awesome. Mm-hmm. So you had mentioned earlier about cadaver grafts versus non-cadaver grafts. Let's talk about that. How do you choose between autograft and allograft?
So there's three typical autografts that we can choose from. One is the patellar tendon, which is probably the gold standard. It's been around the longest, where we use the middle third of the patellar tendon as a new graft, which will become a new ACL. We also can borrow the hamstring tendons that come down and attach below the knee, and that's a very established technique. And then more recently, in the last 5 years or so, there's a quad tendon graft that people are using, and those three grafts are all of them have shown very good results, and there's not necessarily one that is better. Otherwise, we would all kind of steer towards that one. And that's used mainly in our younger patients. Once patients are in their late 30s to 40s, we still can use those grafts, but I tend to recommend an allograft. Allograft means it's not from your own body, it's from a donor. And the donors are screened and they're safe. And that graft is something that we can get. It's actually in a freezer, and we prepare it just like we would your own tissue. And we do that surgery in a very similar manner, where we put it in the knee. And then over time, your body actually changes that. And it's basically a scaffold right now. And your body will incorporate with cells, and it'll become a ligament over time. So it's fascinating. It's great. That became very popular years ago. And when we started to use that graft in younger people, there was a little bit of a higher failure rate. And most people feel that failure rate was higher because it is less painful, and the recovery initially is a little bit easier because it's less surgery on your own knee.
Right.
And we probably had young teenagers doing more than they should and stretching it.
Got it.
Or having it fail before it was solid.
Yeah.
So if a teenager wants to go back at 6 months and the allograft may not quite be ready yet, they're at a high risk for re-tearing it.
I see.
So I try to avoid allografts in my younger patients. I do use it for revision surgeries.
Okay.
Yeah.
Wow. Yeah, so it sounds like it's a real process either way to get over it. But with the cadaver graft or someone else's tendon, the pain is less. And so now let's talk about recovery. What happens in the first 2 weeks after surgery?
Okay. Patient goes home after surgery, and it's the first few days is really a lot of icing, maybe narcotics, pain management, anti-inflammatories. And we usually use a long brace that just holds the knee. We want to focus on getting full extension of the knee, straight, so the knee is fully straight right after surgery over the first few weeks. And we start therapy right away, typically a week after surgery. We try to get people to wean off of their crutches by the end of a week. And then from there on, we really rely heavily on our physical therapists. I think they really do a great job. It's a pretty quick progression to even getting on a stationary bike. Usually we can have people on a stationary bike by week 4. And moving on to that, it's really about getting the full range of motion and all of the flexion back. That flexion usually comes a little bit later than the full extension. And then, as I said earlier, jogging or straight ahead running by around 3 months. And then it takes people 6 to 8 months to have strength that's equal to their other leg. So a lot of times I'll have people, especially my high school and college athletes, I'll have them do a return to sports evaluation where they get put through a battery of tests just comparing the two legs. And as long as the strength is good, then we clear them for sports.
Yeah, it was incredible to me how my quad just would not work after the surgery, right? It's gone.
It shuts down, it atrophies quickly, but luckily it has good memory and it comes back.
Right, it does bounce back, yeah. Absolutely. And yeah, PT is so key. I can attest to that as
Mm-hmm.
well. Returning back to our usual activities, when can someone return to work usually?
So it depends. If somebody has a desk job, I'm comfortable as soon as they're able to get around. If it's their right leg and they have to drive themselves, I'm okay with people driving after ACL surgery as soon as they're off their narcotics, and as long as they feel safe, they can push the brakes and push the gas. So that's usually by the end of the first week.
Yeah.
And if you have a desk job and you're not moving around too much, you can go back to work that quickly. If you're on your feet, construction, nursing, physicians that are on their feet a lot, it might be a couple weeks.
Can people return to skiing safely?
Yeah, absolutely. I mean, as long as the surgery goes well and the knee is stable and the strength is back, I fully expect people that want to go back skiing can go back skiing.
Do you recommend it?
Yeah.
Okay.
Yes, I do.
My husband likes that. What about re-tearing? I hear of a lot of people, injuring their ACL multiple times. Tell me about that.
So can be two different reasons for re-tears. So certainly if the surgery is not giving the knee the stability that we intend by doing the operation, if the knee is still loose, then you can have a re-injury more likely. So that's our job as the surgeons to try to make sure the knee is stable. But certain people are at higher risk for tearing their ACLs to begin with. And so that category person, even with a well-done ACL surgery, has a higher risk than the average person to have a re-tear. What we find is if the surgery is doing well and they pass their return to sports evaluation and the knee is stable on the examination, if somebody re-tears, it's actually, or if somebody tears their ACL, it's 50-50, whether it's the same one or the other one. But again, it's a certain patient population that is at higher risk.
And which population is that?
So much more common in young women. Okay. And it is more common with certain sports. We're seeing a lot more ACL injuries with turf fields.
Oh, interesting.
And certainly, as with skiing and basketball and sports that are cutting and pivoting sports, that increases people's risk. But young females are at 3 times the risk of other patients.
Interesting.
And it's multifactorial. Some of it relates to their alignment and how they land when they jump. Some of it relates to the size of the space in the knee where the ACL lives. And if it's a very narrow area, then a little bit of rotation can cause damage to the ACL. And then there's thoughts that perhaps there's some ligamentous laxity associated with their where they are in their menstrual cycle. So there's been some studies that have looked at that, suggesting that might play a role.
So let's talk about prevention. I know most of our listeners would rather not go through any of this at all. So are there any techniques or training methods that can reduce ACL injury risk?
Yes, absolutely. And that's been actually published fairly recently, that they've found a very strong hamstring strengthening program can help. They've done some studies on women's soccer teams, and they've put them through these preseason programs, and they've showed a lower incidence of ACL tears. Unfortunately, we don't find that a brace prevents ACL tears. So you might say, well, wait, all those football players, they're all wearing braces, they're the linemen, and they are, but that's really to prevent MCL injuries. And so we don't have a way to prevent it by bracing the knee that's reliable, but certainly being in better shape and condition for your sport and doing some of these hamstring strengthening programs can be beneficial.
Okay,
Yeah.
awesome. And where can people find those programs?
You can go to the American Academy of Orthopedic Surgeons, AAOS website under ACL, and they'll have something there.
Awesome. All right. So any particular advice for our weekend athletes heading into the ski season or out of the ski season?
Sure. Well, heading into the season, obviously strengthening
Yeah.
is important. Probably if you're not an experienced, well, at any level, your bindings should be set properly. So if the ski releases, you're going to have a better chance of not having that phantom foot phenomenon, the one that I talked about at the beginning of the podcast, which if the ski releases, you're not going to have that lever arm and that stress on the knee. So loosening the bindings, lots of quad, core, and hamstring strengthening. And that's the only thing you can really do.
Should people do stretches before they go out on the mountain?
Can't hurt to stretch, but I'm not sure that affects ACL injury rates.
All right, good.
Yeah.
I'll just not be that random weird person stretching before the mountain. All right, how about strengthening strategies for protecting the knee? We already kind of hit on some of them.
Yeah, really, it's the what we call the posterior chain in the leg, which are the hamstring muscles primarily, because they help to keep the shin bone, the tibia, from moving forward. The hamstrings are very important. So balancing out your quad strength and your hamstring strength is important. Most people are quad dominant. They have more strength in their quads.
Right.
So
let's talk about the emotional and lifestyle impact of these injuries. What do patients struggle with the most mentally after injury?
I think the biggest issue is probably, oh my gosh, am I ever going to be the same again?
Right.
Will I be able to perform at the same level? Most of the studies on ACL recovery shows a very high, greater than 90% return to sports at the same or even higher level. So people should understand that, yes, it's a terrible injury to have to go through, and it definitely interferes with your life. And, in high school, every year is critical now. There's no good time to tear your ACL,
Right.
but that you really can try to spin a positive and you can work on other aspects of your athleticism while you're recovering from your ACL, and you should expect to still be able to get back to your sport.
That's wonderful to hear. Seriously. Thanks. I'm so glad you do what you do, because I can't even imagine my life without ever being able to return to tennis or maybe skiing. All right. So for our Capital Region listeners, are you seeing more ski-related injuries over the recent years?
Yeah, it's been pretty steady. I don't know that we always see a rush of ACL injuries when the snow comes, but we also see a rush at the beginning of the fall school season when the football players and the soccer players start. So there's kind of a little bit of a seasonality, but
Sure.
this was a pretty good ski year for the Northeast, and so we did see a fair number.
Right.
Yeah.
How quickly should someone get evaluated after a knee injury on the slopes?
If you can bear weight and you have some swelling, you're probably safe to ice and use some Advil and wait the weekend and try to get into somebody early in the week. If you can't bear weight and that's very painful, then we want to make sure that there's not a subtle fracture or something else. So that should be more of a right away urgent care type of thing.
Okay. So it's okay for someone to try to walk it off and take some ibuprofen. Yeah. Okay. All right, Dr. Flake, if there's one thing every skier and active adult should understand about ACL and meniscus injuries, what would it be?
Well, I guess the one thing, again, the take-home message might be that it's a common injury and that people do very well overall. Obviously, every surgery has some risks, but the overall, it's a very common injury, so we're getting very good at repairing these, and that your life isn't over.
Love it. And you get to sport a nice brace for a little while. Right. It tends to go with all your outfits. Right. Actually, I wore it. We went out for a Valentine's weekend a week after your surgery, and I wore the big immobilizer to the restaurant. Worked out just fine.
They gave you a nice seat, probably, right?
Yeah, they did. They totally did. Yep. Thank you. Sure. Dr. Flake, thank you so much for joining us today. And I'm really, really glad that we were able to elucidate what happens with these ACL injuries. And hopefully we can prevent some. And if you do have an ACL injury, you know where to go.
Thank you very much. My pleasure.
Thank you. And that's a wrap on today's episode of 518 Thrives Healthcast, where medicine is human, prevention matters, and your health actually makes sense. If this episode helped you, taught you something new, or made healthcare feel a little less overwhelming, share it with someone you care about. That's how we help more families across the 518 stay informed and stay healthy. I'm Dr. Disha Spath, reminding you that the best healthcare starts long before the ER, long before the diagnosis, and long before the crisis. Stay curious, stay proactive, and keep thriving.
This podcast is intended for educational and informational purposes only. The content of this podcast, including discussions with expert specialists, is designed to provide general knowledge about common health concerns and related topics. However, it does not constitute medical advice and should not be relied upon as a substitute for professional medical consultation, diagnosis, or treatment. Any cases or scenarios discussed in this podcast are fictional or generalized and do not reflect real patients or real-life medical cases. If you have specific health concerns, please consult your own physician or qualified healthcare for personalized medical advice. The opinion expressed by the host and guests do not necessarily reflect the views of any affiliated institutions. Any reliance you place on such information is strictly at your own risk. This podcast is a production of TFP Communications, LLC.